The first thing we're going to do is talk about the hip joint. Of course, humans have two hips, and some joints need to be mobile and some need to be stable. In the case of the hip, we need both. We need a great deal of stability and mobility. And the way that the hip does this is by being a synovial joint, first of all, which allows movement. It's a multi-axial joint, or a ball and socket joint, which allows 3 planes of motion, sometimes referred to as 3 degrees of freedom of motion. And also we have a femoral neck, which is offset by about 120 degrees, which allows a big range of movement, but also retains stability as well, which is important. You will encounter a lot of hip pathologies in various aspects of physiotherapy. Probably the commonest conditions that you're going to encounter are going to be osteoarthritis, which we'll talk about later in the semester. Fractures of the femoral neck are very common. There are some congenital defects which you will come across as well, and some other quite interesting conditions where the mechanics of the hip is not as it should be. And sometimes we get extra layers of bone put down where we get kind of pincers that can cause compression of the hip, and there's a labrum that goes around the outside of the socket, and that can sometimes become torn. A similar kind of thing happens in the shoulder as well. So we're going to talk about the bones first of all. Another name for the hip joint is the coxal joint, and we have one on each side, and the hip joint is between the head of the femur, which is roughly spherical, and the acetabulum, which is the name for the socket formed in the pelvis where 3 bones join together. There are 3 bones in the pelvis on the left side and 3 on the right. There's the ilium, the ischium and the pubis, and they all fuse together in the central socket called the acetabulum. The acetabulum is sort of an egg cup, and the femoral head is like an egg. So the hip is quite stable. It takes a lot of force to dislocate a hip. You'd have to be quite unlucky to have a dislocated hip. It can happen. It can happen in sports, or it can happen in a car crash. Quite often a front-end collision will drive the femoral head out of the socket and you get a posterior dislocation of the hip. But generally speaking, the hip is very stable. That's not quite the same as a hip replacement. They're less stable, but a hip itself, a normal human hip, is very stable. One of the things that makes it even more stable is a layer of fibrocartilage which wraps around the hip joint itself, rather like sellotape holding an egg in an egg cup. That's called an acetabular labrum. Both bones are covered in articular hyaline cartilage, which is a soft, spongy, slippery substance which is very good at absorbing stresses and strains. The interesting thing about a joint such as the hip is that the 2 surfaces don't fit together perfectly until you actually take weight through them, and that's deliberately designed that way so that there's deformation of the cartilage and nutrition can get to the cartilage. Because the cartilage is quite soft and spongy, if you did have a nerve or a blood vessel going through that, the first time a toddler stood up, those tissues would be damaged. So you can't have vascularization or innervation in the cartilage itself. You have to feed the cartilage from the outside in, which is something called synovial sweep. So movement is very important for nutrition of cartilage, which you'll talk about much more. If you have a look at the femoral head, you'll notice that there's a central depression on the top of the femoral head. That's called a fovea, F-O-V-E-A, and a ligament attaches to that and goes from the head of the femur to the base of the acetabulum, and that ligament is inside the hip joint itself, and it's called a ligamentum teres. A slightly odd ligament. We're not too sure what its function is, but it does seem to supply blood to the femoral head, particularly in younger people. So sometimes after a dislocated hip, it's not unusual to get death of the femoral head because of the disruption to the ligamentum teres, and that's called avascular necrosis. In terms of what the hip joint can do, it's a multi-axial, spheroidal, synovial ball and socket joint, which means it can pretty much do everything. It can move forwards and back, which is flexion and extension. It can move side to side, which is abduction and adduction. And it can rotate, which is medial and lateral rotation. And it can do a combination of these where the hip traces out a cone, which is called circumduction. Because the hip is a large joint and it takes a lot of stresses and strains, it also needs to be stable, so it has a very strong capsule. So what we're going to do is imagine that we're shrinking ourselves down so that we're injected into a hip joint and we're going to stand on the femoral head. The first thing that we notice is that we fall off because it's extremely slippery. Somebody has calculated that the coefficient of friction between two normal articular surfaces is 1/10 that of an ice skate on ice, so it's extremely slippery in a normal joint. It should be like rubbing two ice cubes together, it should be so slippery. So we have to climb back up and hold on to the femoral head. The next thing that we notice is that above us is more cartilage, which is the acetabulum, and around our ankles, sloshing around, is a very small layer of synovial fluid, which is a really viscous fluid, but it's a really interesting fluid. One of its properties is called thixotropy, which means that the more we move it, the less viscous it becomes, the more runny it becomes, a little bit like tomato ketchup, which we'll talk about more in class. There are three main ligaments that we need to know about, and each ligament comes from the corresponding bone of the pelvis and goes to the hip. So we have an ilium, an ischium, and a pubis, and a femur. So we have three key ligaments. We have an iliofemoral ligament, an ischiofemoral ligament, and a pubofemoral ligament, which we'll come to in a second. So if we look around when we're standing on this femoral head, we also see above us a very thin membrane called a synovial membrane, which is producing a very small amount of synovial fluid. If we take this off, moving our way towards the surface of the body, we then find ligaments. Now if you look in an anatomy book, the ligaments will be described as three distinct bands. Actually, if you look at an autopsy specimen, what you see is a bag, a capsule that holds things together, and that bag has three areas of thickening, which are these ligaments. So you have a capsule which is like a big carrier bag that holds everything together, but with three different thickenings. Have a look at the attachments of these ligaments. They basically go from around the acetabulum to the neck of the femur. The iliofemoral ligament is at the front. It's actually the strongest ligament in the body, and we have a pubofemoral and an ischiofemoral ligament as well. We're going to now talk about the movements of the hip. So we have three planes of movement. We have flexion of the hip, which is bringing your knee towards your tummy, extension of the hip, which is taking your leg the opposite way, abduction means taking something away, so it means taking your legs apart, adduction means bringing your legs back together again, and then we can rotate as well. All of these movements have a fairly large range. It depends on the person, it depends on the shape of the femoral head, it depends on the gender, it depends on various things. We need to know what normal range is before we can look at abnormal, and you'll be provided with details about what normal ranges are. Another thing that we need to think about is the end feel. Now the end feel is the quality at the end of the movement. So on a normal hip, if we bend somebody's hip up towards their tummy, a normal end feel is soft tissue approximation. In other words, that means that the abdominal contents press against the femur and you won't get any further movement. Hip extension is usually what's called a hard elastic end feel. So that's a little bit like getting hold of a leather belt and trying to stretch it. It doesn't come to a grinding halt, but it's fairly firm. That's usually the quality of ligamentous limitation. So most of the limiting factors in the lower limb are going to be ligament tightness. When we abduct our leg, again, various things can limit that movement. So one of the things that could limit abduction is tight trousers. You need to think about that in your patients. It could also be the muscles on the opposite side. So if you're abducting your leg, it could be that the adductor muscles are being stretched, or it could be that the capsule on the medial side is causing limitation. If we look at adduction, the most obvious limitation of adduction is hitting the other leg, or again it could be tension in the lateral muscles, the glutei medius and minimus and tensor fasciae lata, or it could be capsular. Limitations to rotation are a little bit more tricky. So if you medially or internally rotate your hip, it could be the lateral rotators or the lateral part of the capsule that's causing limitation, and vice versa. In terms of accessory movements at the hip, so an accessory movement is something that is normally needed for normal movement, but not something that we can voluntarily do. So if I asked you to hold your hand up and lift your finger up in front of you and spirally rotate your finger, you couldn't do that. There is no muscle that does that. But if I threw a tennis ball to you and you caught it, your fingers would automatically rotate spirally to accommodate the ball. Because the hip can pretty much do everything anyway, there are not many accessory movements in the hip. Pretty much all we can do is distract it, so we can actually do an accessory movement where we apply an inferior and lateral glide or a distraction to the hip, and we can actually slightly pull the femoral head away from the acetabulum.